All right, guys. So we are live. This is a live stream, and we're going to discuss yesterday and today's case study that I had using the PulmoVista 500. It's electrical impedance tomography. Use that to guide the recruitment of dorsal atelectasis in a 27-year-old autistic woman with positive for influenza. As well as sepsis that also has infiltrated the lung. So now we're having lung issues. She had decreased level of consciousness in the ER. Now that I've looked into a little bit more the backstory and stuff like that, electrolytes were out of whack. So she came in very sick, decreased level of consciousness, and was intubated. So I put on I walked by and so I was like, she's on 100% oxygen, and she's satting 88. She was on ACPC. I believe it was like a ACPC PEEP of 8 and peak inspiratory pressure. We were using the Draeger V500, and it was 32. So that's pretty large drive pressure. And with that, we were getting 6 cc's per kilogram, around 300 of tidal volume. So even doing like an incremental PEEP, trial, or trying to recruit with higher PEEPs, I didn't want to staircase like 8 and 32 to go like 10 and 34 and up and just keep on staircasing it like that. So when I put the PulmoVista 500 on, sorry, the granddaughter is, we just put her to bed, but she's crying. Sorry about that, unexpected. Okay. So anyways, so we have this young girl. She's on 100% oxygen. She has very high drive pressures, pretty limited in increasing the PEEP, because that's going to increase the plateau well above 32, right? So since it was already there, you'll see in the video that with the electrical impedance tomography that it's like a kind of like a ARDS baby lung looking image. Don't forget, the PulmoVista shows you an image that is the same perspective as a CT scan. So you're looking at caudal to cranial. So it was really just all up into the ventral areas and the mid-ventral areas, very small amounts of dorsal distribution. So that's like a horror show for that person's lung. So I gave you a little bit more of a complete backstory to it. So since we had a peak pressure of 32, or a plateau of 32 in ACPC, we transitioned to APRV with a P high of 32. We use a TCAV method, time-controlled adaptive ventilation. I think pretty much everybody is using that now with the P-low set at 0. And what we're doing is we're stopping the release, or we're air trapping when the peak expiratory flow descends to 75%. Then we stop the release. So it's pretty easy on the Draeger. I use the auto release. I set it at 75. Therefore, the minute it releases that peak pressure, let's say it's 100 liters per minute, and I have that expiratory termination for that release at 75. That means that when it hits 75 liters per minute, which is very brief, we're right back up to the P high. So that all the recruitment that we're getting with the extended T high, which is going to be pressure, right? Recruitment is pressure over time. So we have that pressure over time with the P high and the T high, but then we don't want to lose all of that recruitment once we do that release. And Dr. Nadir Habashi and a lot of the pig models have shown that if we are going to release passively to ambient air, if we stop it once it gets to 75% of the peak expiratory flow, we do not lose the recruitment that we obtained on the P-high. So I think I gave a lot better backstory to this case. So once I put it on, like I said, on ACPC, total, dorsal atelectasis was, there's no distribution there. Everything was stuck up on the ventrals. She's on 100% oxygen. She's satting 87. She has a respiratory rate that's 30, and we still have, acidosis with a PCO2, and we'll see the blood gases later on in the video, around 60. So like she's acidotic, where she's hyperventilating, she's hypoxic. Things are not going good, and this is like a really, really good case study. I got this patient from this 100%, right, to within 24 hours on room air, lung completely recruited. And I did mention, right, she had scoliosis. So the scoliosis works against her once she's intubated, likely the like severe scoliosis. Creates that restrictive lung disease, and on top of it, you're sick, you have lung issues, you're intubated, you're no longer standing. So all of a sudden, she probably likely is super predisposed. I bet you once we try and start weaning, we might have issues with the dorsal aspect. So I'm going to post over here an invite for other professionals that would like to come and join. Ideally, this is a live stream. I've already posted this in my videos. A lot of these videos are while I'm at work. I'm literally just filming the PulmoVista screen, filming the vent screen. I'm busy. I'm trying to just kind of like document this good example as much as I can. So in retrospect, looking back, I'm like, you know what? Like, there's a couple of things I didn't even know I should have, but it was actually a super busy day. So it was like rock and roll. And on top of that busy day, I took the time to really fine tune this patient. So let's look at the video, and we can discuss if anybody wants to come on. There's 3 people at the moment that are viewing, which is pretty cool. I'm streaming on Facebook as well as my Twitter. And if you want to follow me on my other channel, it's Jason John Swartz. Find me on Facebook with a black and white profile if ever you want to friend me. Ideally, what I'd like to be doing for this channel is having people come on, and if you have a really cool case study on something related to our profession, you can come, we can talk, we can have like discussions and debates, whatever you want. So yeah, that's it. Let's get into the actual video. Like I said, if you just want to see the whole video uninterrupted, feel free to just go to my last post. But if you would like to discuss more, ask questions, if you have any questions about electrical impedance tomography, the PulmoVista, any questions about APRV, please feel free to ask those questions, whether it's in the comments, or you can come on live as well, and we can discuss. We've been using APRV with the Draeger V500, using the time-controlled adaptive ventilation method that, like I said, I think is becoming pretty, like mainstream. Dr. Nadir Habashi, you can look up Draeger, Nadir Habashi, and he has a lot on APRV if you're interested. All right, so just gonna pop up on my phone. Just want to make sure what I'm seeing is what you guys are seeing as well. Just give me a sec, guys. make sure that I'm streaming correctly. If there's anybody here, there's 3 people watching. If you do me a favor and give me a thumbs up in the comments, it would help to see. I'm trying to find myself on my phone. It's always a good idea to be watching on another screen because sometimes you might have something that is not functioning well. Won't be long, won't be long. Come on. Yep. Cool. All right, perfect. All right, let's do it. We're going to start the video for you. I had a patient that was on ACPC with a peak inspiratory pressure setting on ACPC of 32. With that, there was a PEEP of 8. The volumes were around 300, which is 6 cc's per kilogram for this patient. She has seizures, she is septic, but now suddenly she's on 100% oxygen. So we put the electrical impedance tomography belt on the patient, and this is what we saw. All right, so when we're looking at over here, this is on ACPC with the PEEP of 8. We were getting with a peak pressure of 32 set, so that's a large drive pressure. And we were still just with that getting for her 300 and some tidal volume, which she's small, so that's like 6 cc's per kilogram of ideal body weight. But we can see over here, think of this as a CT scan, and this whole blue and white stuff is aeration. So this would be all the aeration is trapped, okay, on the ventral and mid-ventral area. There's a little bit here in the dorsal area, but not very much. Over here, we'll continue, and I'll let it go for a bit. Over here, you can see that the ventral or the right upper quadrant and the left upper quadrant of the lung has the majority of the distribution. Very poor in region 3 and 4, the dorsal regions, and we tried APRV because ACPC wasn't helping at all with anything. APRV was just kind of creating a stronger white band across the chest. All right, so here I am saying like, oh, the APRV is creating a white band across the chest. Well, I have to explain what white means. Okay, so wherever there's blue, that's where the volume is being distributed. There will always be within the aerated blue area, there will be white. Okay, and the white is very, very useful in showing us where a higher amount of the volume is being distributed. So this here we see, okay, yeah, there's aeration on the top, and obviously because there's hardly anything at the dorsal region, this majority of ventilation, this white appears here, and the more intense it appears, you want that that distribution to be evenly distributed as much as possible. So you don't want like these like big white spots maybe on the right upper quadrant area or anything. You want it as smoothed out as possible. Obviously, we're trying to open up the dorsal region, but the risk of hurting the ventral over a long time. So since the APRV didn't work, I said, let's prone the patient so that the ventral areas here will have the body weight, and we'll remove all the body weight from the dorsal area. And within a very short time, if you look over here, in a very short time, So this is where we started out, okay? The electrical impedance tomography, the PulmoVista 500 by Draeger. Go see some of my archived videos. I have like introduction to electrical impedance tomography. I have a EIT, guided mechanical ventilation. I have PulmoVista 500 guided APRV cases. So for this one here, you press the reference, so everything, okay, the reference becomes locked in, and this reference was the ACPC. And then after, because we're connected to the Draeger machine, it knows all the different P high levels that I was adjusting. So you can see up here it's going up and down. I'm trying various P high levels. And so what I'm doing now, I'm scrolling back so that my reference and my control area are equal. And we're going to start scrolling as we go down the timeline. And you're going to see that with APRV, as mentioned before, APRV, we had APRV of 32 P high. With I think maybe we started with like 3 T high extension, and a little bit. There was like a little bit better here, and all I saw was just more and more of the vent power being distributed to the ventral areas. So obviously, the ventral areas are the most compliant. They're the least affected. They're the most healthy, we could say, and because the dorsal, we're trying to open it up. There's always that danger of like just not succeeding and everything being transmitted over time to the ventral areas. And then that's why, you can get ARDS and it can be so deadly. So my idea, my suggestion was, and I've done this 4 times so far. I think I have 3 videos of exactly this, trying with conventional, going to APRV, still doesn't do the trick, but then flip onto the prone position, put pressure on your most compliant ventral areas in a way to protect it and encourage, the power of the vent to go to the dorsal area where we want to open up. This was a very, very satisfying case, very impressive results. And I'll let this play a little bit more again. Do you see here now? So this is now in the prone position. So now this here, okay, is the chest is lying down. All the body weight is here now. So we can see that there's less distribution, and this is strictly positional change. So all of a sudden there's less power going to distribution going to the ventral areas. The body weight is off of the lung. The heart weight is off as well. And almost immediately, with the same amount of vent power, we're getting an opening. Okay. And notice, again, see this white that was a concern? The white has become more evenly distributed. It's less intense, and that's exactly what we want to see. Let's continue.
Improvement here in this region. And again, a color-coded way of expressing this is the reference here, okay, prior to proning, and then proning. Okay, supine, proning. What happened here is when we opened up the dorsal regions, well, volume was able to be distributed from there. So that took a lot of volume from the ventral areas. So that's a good thing. This is the color-coded expression of the dynamic shift in ventilation comparing your reference to your control. So it's saying, look, up here, look how much ventilation there was. Look, there's less here. That means less is orange. Look, see here, there's more starting to appear here. That's represented by blue. You can also look at impedance curves when they have an upward trajectory. Usually means that you are recruiting or augmenting, increasing the end expiratory lung volume. Over here, I'm using the end expiratory lung impedance. So this is to...
Sorry, I'll just rewind it. So I just want to make sure that it's clear. Looking over here one last time. The reference is here. We see the blue is the distribution of ventilation. We see it's all trapped in the ventral. We see significant dorsal atelectasis or de-recruitment. We see the white that is telling us that the majority of the ventilation, where there is aeration, is all in the ventral area. So, that is not in the gravity dependent areas. So we turned the patient over into the prone position to make this area the gravity dependent region in the prone position. This helped protect the more compliant, healthy lung area by having the patient's body weight kind of like splinting, and then after liberating the body pressure from the dorsal area, and right away we see that it's starting to open up. Orange means less distribution of ventilation, and blue means a gain in distribution of ventilation, and it's always compared to your reference. So we see here that the white, shows that a majority of ventilation is going there. And we see that it's less intense, the white, because it's been evenly distributed a little bit more because now we opened up. So when compared to here, there's less ventilation, it shows up orange. And when you gain in an area, it shows up in blue. So orange doesn't necessarily mean bad, like, oh, orange, you lost ventilation. Oh, blue, you gained. It's like, no, it's good. Well, you have to look clinically what's happening. In this case, it is a good thing that there is less distribution of ventilation here because there was way too much there. And now that it's opened up, we see the blue here is representing. So there's a loss in the ventral areas because it's being redistributed to the dorsal areas, which is exactly what we wanted. So this result happened quite quickly. If you look here, I am here. It says 12:43, and by this time it's 14:11. So it's like not even 2 hours.
Volume. Over here, I'm using the end expiratory lung impedance values. So this is to see if you're going to be recruiting at the end of expiration, your functional residual capacity. So again, we're going to be focusing on zone 3 and 4, where there was hardly any distribution. You can see the percentages here.
So that's it. The last screen that I was showing you was end inspiratory lung volume, so recruitment. Now what we're looking here is we're looking at the amount of lung volume at the end of expiration. We could say this is looking at our functional residual capacity, whether we're recruiting or we're de-recruiting. The impedance values, when we talk about impedance, lung impedance values, the more volume there is, the more impedance to the electrical signal there is. And the less volume, the less impedance. So we have 16 electrodes sending these signals across the chest. I believe at 50 hertz, 50 frames per second. It's pretty fast. And it's taking all of these impedance values during the patient's breathing cycles. And it's able to take these measurements and create a image of the distribution of ventilation for us. I don't know if I have time now, but we could go, and it is extremely accurate. I've done in previous videos when a patient has to go for a CT scan, so I happen to have the PulmoVista, whether it's before or after, and we compare it to the CT scan. As far as obviously we we can't see tissue, we can't see inflammation, we can't tell the difference whether it's atelectasis or consolidation with this device. It's really just showing us the distribution of ventilation. But when you look at the CT scans of these areas where there's, dorsal collapse or dorsal consolidation, and you look at where the aeration is, and you look at the machine, it's almost like spot on when it comes to the accuracy. So this is an extremely accurate technology. I can maybe after this show you.
Here, so I can start with the reference, and now I'm going to start scrolling down the timeline. So this was prior to proning, and now we're going to compare after proning. We can see, especially in zone 3 and 4, the two most important parts that we're trying to recruit. We have positive impedance values. We know that we're recruiting volume, and we can see that shown through color, meaning 38 and 15 are positive impedance values. Positive impedance is shown in blue. We see that there's a loss in the ventral areas, which is great because it's not a loss, it's a redistribution. A loss in this area, but redistributed to the area that we actually want. Patient right now is still on the transition. I went from peak inspiratory pressure of 32 to P high of 32. And at the end of my shift, I'm going to try, or tomorrow, to put 32, 30, 28, 26, see if the patient still requires the 30. And the blood gases were good here with a rate of.
All right. So yeah, it's pretty impressive. So the patient, was breathing on ACPC, had a rate of 30. It was like 7.2 something. And I remember the CO2 was 60. The minute that we put the patient on APRV, I think I left my shift maybe with a T high stretched at 3 about. And when I got there the next day, my colleagues had stretched it to 5, and then I further stretched it to 6. Just looking at, the previous rest rate that was like 30, and then by the end of my shift, 14. When I got there back in the morning, the patient was just allowing herself to be ventilated. Yeah, by the time the morning came, they had stretched it to 5 seconds. So that was like 11 releases here where the CO2 is evacuated. And then I brought it to 6. So then the rate was 9. She had rocuronium, 50 milligrams PRN. Majority of the time we didn't need it, except for when we were changing the positions that would stimulate her. So I'm off to tomorrow, so I can't wait to get back for Tuesday. We want to, get her breathing as early as possible, on APRV. So the other thing is to keep in mind is look at the mean pressure, this 29. When we turned her today on her back, everything looked good. The volumes were 412. Everything looked nice. She didn't desaturate. I put her on 21% just to prove a point. She was satting 96. Everything was good. But when I did put the electrical impedance tomography, once she was back on the supine position with a P high of 30, she had already started losing the dorsal distribution. It started to go back to how it looked. Likely, a large part of this is the scoliosis too, in hindsight, So what I'm saying is once we flipped, she's on 21%, her volumes are 412. Hey, now's a good time maybe to start trying to wean down. If I wouldn't have put back on the tomography to realize that with the p high of 30, it was already closing up. I was able to do a trial of 30 p high, 32, and 34. I did that with PulmoVista, checked the regional compliance, and at 34 was actually, there was no evidence of loss of compliance compared to 30. There was, in fact, a slight improvement. I didn't feel it necessary to put it at 34. At 30, she had 8 cc's per kilogram of tidal volume. She didn't desat. She does have, this restrictive lung disease. So by doing 30, 32, and 34, and knowing that 34 was actually optimal compared to 30, I was a lot more comfortable to just leave it at 30. And I knew, like, forget about the idea I had yesterday of 28 and 26. The other thing too is I've noticed when I have APRV on and patients start breathing on the P high level, these spontaneous efforts where they're drawing in air, if the lungs already well recruited, okay, and then after you're making additional inspiratory effort, it usually like distributes to the gravity dependent region. So I've noticed too that once they resume spontaneous breathing on that P high level, you get an even nicer distribution of ventilation many times. I think the big difference with APRV now is that by using the P low at 0 and doing the time controlled adaptive ventilation, air trapping 75% of the peak expiratory flow, when it's released, it's not released through a PEEP valve, right? It's just released to 0, to ambient. So it creates a nice delta pressure gradient, and the release is brief, but it's able to eliminate a good amount of CO2. Very impressive. It just shows like that when that patient was on ACPC, PIP set at 32, PEEP of 12, rate of 30, CO2 was 60. I mean, it was not a good situation at all.
14. Prior to that, we had a much higher respiratory rate when we were on the ACPC. So I don't want to go too much. Give me a second. I'll press pause. It's already changing even more. So
that's already better, and that's probably like a few minutes into it. I'll let it play again. I like it. It looks like eyes and a mouth.
Really see now that it's been completely
look at that,
recruited.
Look at what we were starting with. So ideally, I put it in quadrants, so there should be 25% evenly distributed. When we first started up here in the right upper quadrant, so the right ventral and mid-ventral combined, 57% of the volume was going to the right upper quadrant. That's horrible. Half of all, this poor little section here had to deal with half of all the vent was delivering. So we see 47, 35, and then we see 3 and 4, the dorsal regions, only 9 and 9%. Here we can see already that now we have 29%, we have 34%, 21, 16. We see that they're getting closer and closer to 25% in each quadrant. When one's family was asking, when I'm talking about like rest rate or something, I'm talking about the cycled releases. After the T high, it was a 5-second every one of those releases. That's what I mean. So the patient was just not breathing spontaneously above, and for sure, like the patient's prone, so the sedation's deeper. And but the patient was super comfortable. We didn't have a rocuronium infusion the whole time. Probably needed a bolus initially. So when I did stimulate her at one point and change the head position, she started, to react, and she started to breathe and take in breaths, which was actually quite useful because I was able to look with the p-high of 30, and I could see like the brown spontaneous inspirations, and even with quite a high p-high. She was able to suck in some decent tidal volumes. So I was quite encouraged by that. That's what I said today. I said, look, she's back on the supine position. And I said, like, be encouraged if she starts breathing. Then I explained, so if you have a P high, obviously, that in a very, very sick patient, you might be at like, max, you might be at like total lung capacity kind of thing. But the minute they start breathing, it's very easy also to kind of like just extend your T high for like 20 seconds or 30 seconds. Start looking at the inspiratory flow, look at it, and then start, let's say, go down by 2. And if you start seeing the amplitude on your inspiratory flow get larger and the volumes get larger, it just tells you right away, oh, you know what, I was probably way too high, and now I've lowered it so the patient has some more inspiratory capacity to move. So once they do start breathing spontaneously, it gives you a lot of feedback, a lot more information. And the fact that we have a P low at 0, when you look at the expiratory flow, that is an accurate representation of the person's lung mechanics, because it's not being the minute your expiratory flow goes through a PEEP valve, well, it's not an accurate representation of your mechanics, but it's kind of like a flow rate. That's what I mean. So it gives you a lot more information.
That's pretty impressive. Look at that. You see it? Where it started within like an hour or two. And it was 100, now to 75%. Yeah, and the chest is only moving 14, and which is good. Okay, so this is again a continuation of the case study that I'm presenting here to you guys.
I'm just going to answer a question here. So patient rate was 9, total cycle time. Yeah, like with the T high set at 5, it was 11 releases, and patient was not breathing above. So, and then, the scoliosis, the map is up here, 28, 29. And see, that's the thing, because there are some doctors that they don't care. They don't want APRV. They don't like APRV and stuff like that. So what happens is sometimes, they'll switch it, and it's like, no, even if you have a PEEP of 18 or something, like you're not going to be able to attain this high mean pressure in conventional modes, in my opinion. Like, how high do the parameters have to be to have a mean pressure of 28? This here is probably a 13-to-1 inverse ratio. We're spending 13 more times on the inspiration or on that P high level than on the low. So it's very important to wean, and as you know, because you're focusing, responding to one family, as you decrease your P high, if you extend your T high, that's a way of weaning down and still maintaining, the mean pressure. So look at that. It's at 35%. When I left today, it was at room air. I was like showing off. I was like, room air. Um, one family is saying, when she was on volume AC, what were the volumes? And then when switched to PC, much larger on the PC. So it was 18, 28. So if it was a set, because the Draeger V500, you're setting your peak inspiratory pressure. They had it at 32. They had a PEEP at 8. Okay, so horrible at math. Is that like a delta P of 24? Yeah, 24. Okay, very high. So delta P, horrible, not good. If we're going by, the drive pressure studies and stuff like that, that's not good. We're increasing, ventilator associated mortality with that very high amount. And like I said, I the patient wasn't on ACVC, so I got the patient just on pressure control. When I saw the PEEP was 8 and the pressure control was 32, and we were getting around 312 tidal volume on ACPC. So she's actually small. That's around 6 cc's per kilogram, which just shows it's like, okay, great. 6 cc's per kilogram. We're not using large tidal volumes, but yeah, but the lung is like completely shut down. And what else are you asking here? So when she was on volume AC, what were the volumes? So I got, like, don't forget, this is like while I'm working. So the decision was I'm putting, the PulmoVista on, see what's happening. Peeps at 8. I just transitioned to APRV for that one. I didn't want to go like 10 and 34, 12 and 30. It was, I was uncomfortable to do that. So I switched to AC PC. I switched from ACPC to APRV. So I used the peak inspiratory pressure of 32 with my starting P high. You also said right about the docs. Most are not always too sure. Yeah. The only reason that we use APRV um, in our ICU is because of the PulmoVista 500. I started to do that, the PulmoVista, and then the APRV. It started during COVID. There was a morbidly obese guy, and I had never tried APRV, TCAV method. I'd never tried any of that, and he was satting like 60 some for like 16 hours, and when I got reported, it was like, the doctors are aware, it's a COVID patient. He's probably going to pass away and stuff. So I didn't have the PulmoVista on that one, but it was the first patient that I tried APRV, and yeah, that the mean pressure that we could attain with APRV was what was required, and his lung opened up, his oxygenation improved, and we ended up, saving that guy from COVID. So that was that made a big impression in the ICU. But it's really going to the patient's bedside, trying the ACPC, ACVC conventional mode, doing an optimal PEEP trial that you can do with your PulmoVista. Okay, it'll show you the optimal PEEP. It'll show you where there's atelectasis, show you where there's overdistension, and give you that optimal PEEP. So, I get the optimal PEEP on conventional, and if the conventional is still not perfect, then I'll keep, because the monitor's on. I'll transition to APRV, and I'll look and I'll make the comparison, and I'll just like bring all of the results to the doctors, and the results are there. So having all of these distribution of ventilation, regional compliance values, and things like that were were a way of, really convincing. Also, when you have somebody who's on 100% FiO2 and within 24 hours, APRV flip like a pancake, bing, bing, boom, room air, that also can have quite an impact. See, the issue is that the patient now is on room air. Okay. Had to keep it at 30. I'll tell you why later. And the volume was 419. The next, because this was over the weekend, so I contacted the doctor that works Monday because I wanted to make sure that everything was clear because I'm not working tomorrow. And what happens is, like, somebody will arrive and we go like, why is the patient on APRV? They're on room air. And and it's like, yeah, I know, like, it's 24 hours ago, it was not the same thing. So over here, look at this, 9 breath, 9. So, it just makes sense to, like, in my head, I'm still trying to keep my P high below 30, still respecting tidal volumes. Personally, trapping 75% of peak expiratory flow with the auto release, the drive pressures are always smaller. When I transition from ACPC to APRV, I've noticed one thing. The 75% falls very often on optimal PEEP. I've noticed that's one thing. So if I do an optimal PEEP and let's say the plateau is 25 and I set my P high at 25, I set my auto release at 75, it'll fall almost exactly on it, or one higher, one lower about. So over here, we have it set at 30, and I believe the drop was the P low was dropping to 75. Sorry, the P low was dropping to 12 and 15, I think 15 to 12. Here, when you add a slope, so ideally don't add a slope. You want really 75% of peak expiratory flow to terminate and to go back up. If you add a slope, what you're going to notice is you're going to notice an increase in the tidal volume. So in APRV, when you see the tidal volume, when they're not breathing, obviously it's measuring the drop here. Okay, the difference. If you add a slope, what happens is the viscoelastic property of the lung. So you see the waveform here, it goes boom, goes up, but when it drops like that, the lung ain't going and then back up. This is the pressure in the circuit going down, and the lungs following behind, and then it's up, and then it's following. So it's like there's a delay. It follows after. It's called like viscoelastic property of the lung. So if you add a slope, then it's during the release, the lungs deflating, and it's because it's not popping up as fast, it's a little slower. You get a little bit, in a way, lower. It drops a little bit lower, and instead of trying to get a little bit more volume, if volume's an issue, and start playing with your 75%, I don't suggest that. You can play with your slope a little bit. And then once your volumes are adequate, you end up weaning this down to 0.0. That's the way I use it. So this is the next day.
This is the next morning. I'm here. We've left the P high at 30. And my colleagues, when I came, had extended the T high to 5 seconds. I've extended it to 6 seconds, and we still have a pH of 7.3, 7.43 and 36, I think, the CO2, which is quite impressive because we only have 9 releases. The release volumes are about 420, which would be 8 cc's per kilogram for her height. And we can just do an expiratory pause because we're using the time-controlled adaptive ventilation protocol, where we keep the PEEP, the PLO at 0, and we create air trapping. So the actual PLO is measured at 11. All right. So waiting for the doctor to find out if we're going to flip the patient back. If we put the patient back supine, I'll do a PulmoVista and see. This is yesterday, and it was similar to previous days. Rest rate was high at 30, and the blood gases with a ACPC were acidotic.
Yeah, let me see over here. Slow it down. Okay. All right. So, yeah, this was midnight. I work day shift, so I arrived right here. You see me in the morning at 9. Switch. So it was on ACPC, 89, 90 sats. Okay. FiO2 was 100. The rate was set. Man, they had a PEEP of 6. Pretty sure it was 8. So yeah, rate of 30, PEEP of 6. That's even lower than I thought. And peak inspirators, that's a huge drive pressure. And so with a high rate like that, and we have an acidotic blood gas. And then this one here, what did they do? I guess it must have magically improved. Okay, let's go a little bit further.
We're acidotic. That continued the.
All right, and then APRV started on 100. I started with a 2.0 and started at 32.
The acidotic.
Then we have a 7.44, 35 CO2. Stretch out my time high to 4 seconds, wean the FiO2 to 85, get a 7.40 and a 40 CO2, wean to 65 the oxygen, down to 60% the FiO2.
Doses, we switched to APRV. She was on 100%. We were able to start weaning the APRV. That was yesterday here. And then after 65, she was.
Yeah, right here. This is the proning. So 85, 65 was after proning, 60 blood gas improves drastically, 7.47 and a 34.
Was prone. Here's a proning around that.
But look at this though. Look at, we're at 7.47. And to be honest, like these are not arterials; these are venuses. So they're slightly on the more acidic side with the CO2 and the pH. So 7.47. It's like we went from like a rate of 30. Now we're going progressively down. We're at 14, and technically we're at like maybe a 7.5. It's like, oh, we dropped the rate by half, and now the patient's alkalotic almost. So anyways, we're down to 14 here, 60%.
That time. And you can see that the rest rate starts going down, 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 down as the lung starts opening up. And
my mentality is, it's mechanical ventilation. It's not natural. Where the lung is going to get hurt when the lung is in transit, when the lung is moving. So if there's anything, in my opinion, if there's anything that I can do that will minimize the chest movement, then I think that it's worthwhile, because it's during the chest movement that you might possibly, have, areas that are not perfect. So since the lung is an organ that uses diffusion, to me, it makes sense that if we can comfortably have the patient splint it open, okay, allow diffusion to occur over multiple seconds, and then when you do release, you release a much more potent bulk ventilation, a release ventilation that has much more CO2. to not take advantage of this organ, which will do its job if you just hold it open, and the oxygen will diffuse across, the CO2 will diffuse across, and you can find the patient's diffusion capacity and just release once. And, we went from a rate to 30 down to a rate of 9. Like, imagine somebody who is on a rate of 30 and has been intubated for a week. Okay, calculate how many chest movements that person went through, and then let's say that the twin, the other one, gets only 9 breaths over a week or two. This is, to me, this is really, really significant. All right, let's just finish this up here. Oops, right. I think I'm not sharing. Sorry about that. Forgot to share screen. It's just me staring at myself. It happens. Just tug it back just a little. There we go. And there you go.
95, maybe 95% sats. So they had stretched it to 5 seconds. There was normal blood gas here on 5 seconds. So I immediately stretched the patient to 6 seconds, kept the 30. And we've been able to wean the FiO2 to 35% now. And the blood gas is even better. So we had 37 for CO2 with 11 releases. And then we extended, and now we're down to 9 releases, and we have an even better blood gas. So here I just want to see you guys to see the chest movement. Barely moves. Very brief releases from the P high. You can see it's a very gentle ride.
Gentle ride, like a Cadillac. All right. Okay, let's stop that one there. And let me show you what it looked like when we flipped the patient back supine. Sorry. Oh, here's another example. Actually, this is not the patient. This is just tons of examples. This is another 24 hours. The majority of these lungs here that I'm turning around are within 24 hours. They're like, yeah. Just a minute. Slideshow. Make it a little bit bigger for you. That's crazy. That is the same lung. That is like started here and put the patient on the PulmoVista, did the whole, setting and stuff like that. But these are cases where like the P high is beyond 30. So, sometimes, let's say, people that don't do their mechanics, and then you look and everyone's freaking out, because I put a P high that's been adjusted with electrical impedance tomography too high, but then I notice sometimes plateau pressures might not be measured and they're very high. So this is a kind of person that was, I believe this one, if I'm trying to remember, was like 12 liters fluid positive. you know, when they're so edematous that like everything's like hard, it feels like the stomach's like that. So of course you can't, you have all this incredible amount of pleural pressure pushing down on the lung. The lung itself is edematous. And, if you're going to be like, oh, we have to keep plateaus at 30 and might not be the best situation. Um, Here's a few more examples I can show you. This is just, I have like all sorts of random examples all over the place. I don't remember anymore what they are. Here's a horrible one too. Okay, very bad. The distribution should kind of, at least be all this area here. Okay, so poor distribution in this one. And then we test various PEEPs. So PEEP of 10, PEEP of 12, PEEP of 14, PEEP of 16, PEEP of 18. So we look at PEEP of 10 over here, 12, 14, 16, 18. Over here, compliance loss with lower PEEPs, compliance loss with higher PEEPs. And what we're looking at here is if you're seeing any white, it's a compliance loss that puts the lung at risk of atelectasis. If there is orange that appears, it is a loss of compliance that may be overdistension or is leading to overdistension. So ideally, when you're doing just a PEEP trial, PEEP study, basing it on regional compliance, you don't want white and you don't want any orange. And we can see here that there is 11% compliance loss. There's 8% compliance loss. There's 3% compliance loss. And we see that the white here is pretty much non-existent. So with a PEEP of just between maybe 14.5 of PEEP, we have no more issues of the lung de-recruiting itself and losing more lung volume. But as we go from 14 to 16 to 18, we start seeing the trend of the lung that is going with orange, meaning 6% loss of compliance, 13% loss of compliance. Keep in mind that in recruitment phases are risky. I mean, doing recruitment maneuvers are risky. So sometimes you're going to have to apply pressure and your readings initially may be orange, but you have to make a decision. Am I going to push through that threshold? And then once it reaches that critical point, it opens up, the orange will not be there anymore. So again, this is a monitor. So you have to use your clinical judgment. It's like, well, what's the tidal volume? As well, what, these are PEEPs, but what are the plateaus? So, you're taking the global values that we have good science on, the ARDSNet, that's kind of outdated now, but overall higher PEEPs, smaller tidal volumes, drive pressures, minimize, lower your drive pressures, like we use that. We don't throw that away, but then we can add all of this amount. I find that it's kind of like a boat that is, looking and is driving towards an iceberg, and it can see the top of the iceberg that's over the water, right? That's kind of us looking at all those numbers on the event screen. But the boat has no idea what the iceberg looks like under the water. And if we don't have electrical impedance tomography, we don't have eyes inside the lung. We can auscultate. I find that X-rays, they do give us a lot of information, but sometimes, it's a lot different, the X-ray and the actual CT scan or the actual impedance tomography. And it's not only that, is that, you can go and, like I always like, oh, great, the patient's going for a chest CT. I want to see the chest CT. I want to, see if there's any atelectasis, consolidation, and stuff like that. But that's just a snapshot in time when they took it. This is at the patient's bedside. It's a belt. You can put this on the whole shift. It's breath per breath. It's dynamic. Then after I transitioned over here, okay, to APRV, I can tell over here because this is still with the PEEP here. And then the PEEP, I tried increasing it to B. Nothing is happening really. I'm not getting I'm getting a little bit of increased compliance here. I'm getting a little bit of decreased compliance there. So I decide, okay, let's see if we can try APRV. If pressure is not working, then maybe we need pressure over time. So let's put APRV on. So over here, C, we see that immediately the compliance compared to the reference is 32% improved. This was our reference. You can see now things are really opening up. You still see that there's still a large amount of ventilation that's on the anterior or ventral part of the lung. That's not ideal, but give it time. So yeah, that's kind of ACPC and APRV did. So this is the last image that I took when we went from prone to supine. So supine position, and started to lose this area, even here too. So what I had to do was do a P high of 30, 32, and 34. And this is what you see over here. It says 30, 32, and 34. Okay. 30, 32, and 34. And so I increased it. What I saw was not much of a difference. There was no win or loss. There was a slight gain. If you look over here, so it goes compliance win, it says 0, 6%, and 9%. The 9% is starting to show up over here. Okay. And I can see a little spot of blue there. So to me, technically, comparing 30, 32, and 34, that means that 30, 32, and 34, 34 would be optimal. But I left it at 30. And what else? Yeah, and then this is, again, I just did a different way, 30, 32, 34. And we can see here that at 30, there's a little bit of white here. So, I mean, I maybe should have actually left it at 32. All right. Good. Any other questions? So I'm just going to read one family. Thanks a lot, man, for showing up. I'm just going to go through the comments. I had answered.